Psychopharmacology, preliminary diagnostic considerations. First, I would like to say that in this course, we are only briefly touching on the major mental health diagnoses. This course is meant to focus primarily on psychopharmacology and not diagnosis. However, in order to adequately discuss psychopharmacology, we need to have a basic understanding of some of the major diagnostic categories that are intended to be treated through psychopharmacology and medications. So, the task here is to give a brief overview of the major diagnostic categories and considerations, enough to give a basic feel for the diagnoses and the mental health conditions, but at the same time to understand that we are barely scratching the surface. So many of you will want to gain more knowledge through other means. Specifically, if you are getting an LPC, you will be required to have a further course that goes over the DSM criteria of the various diagnoses. And if you're getting a good degree through our Master's Rehabilitation Counseling program, you will be required to take psychiatric aspects of disabilities, which does cover the DSM in much more detail, or at least diagnoses in general in much more detail than we do in this course. This chapter, Chapter 6, Preliminary Diagnostic Considerations, to me is a very difficult chapter. I feel like a lot of information was sort of thrown together without much really explanation as to why. But basically, the idea in this chapter is that there are multiple causes of psychiatric symptoms. I might use that term quite frequently in this course, psychiatric symptoms. Psychiatric symptoms basically are the symptoms that result from psychiatric conditions or from psychological conditions. They're symptoms that inhibit human functioning or that cause problems for individuals that are based on psychological or psychiatric reasons. And the most common of these are various types of psychoses, various types of depressive symptoms, and various types of symptoms of anxiety. And the major emphasis of this chapter is to help us realize that there are many and various causes for psychiatric symptoms, and that it is important for clinicians to be aware of this. For instance, if an individual comes to see me or comes into my office with a symptoms of depression, I cannot conclude that because of that, the individual necessarily has a diagnosis of depression as a disorder or as a condition defined by the DSM. There can be many causes of the depression, the symptoms of depression. They can be a byproduct of other mental health disorders, or they could be a result of substance abuse or physical or health conditions. Those are the various broad categories that are discussed in this chapter. As your text points out on the first page of this chapter, it is crucial to keep in mind that any particular behavior, symptom, or trait may have diverse etiologies. In other words, there may be very different or complex causes of that particular behavior, symptom, or trait. That is, identical symptomatic behaviors may spring from biochemical dysfunctions, social learning experiences, or characterological sources. That's a fancy way of saying that an individual's symptoms could be a result of some sort of physical problems. It could be a result of some sort of cultural or psychological factors as well. The three main common sources of etiologic confusion will be discussed in this chapter: the interaction between axis 1 and axis 2, substance abuse and psychiatric symptomology, and finally, physical illnesses that present with cognitive, emotional, and behavioral disturbances. So again, the idea is that there are various causes of mental health problems, and that it is important for clinicians to recognize this and to consider this in both diagnosing people and in considering the best treatment options for individual. Now, first, I would like to give a very brief overview of some of the changes to the DSM that have resulted in the most current edition of the DSM, the DSM-5. As you may have noticed, or as I may have alluded to previously, this textbook was written around the DSM-4 TR. The DSM-5, we were just about 1 year into the implementation of the DSM-5, and it takes quite a while to absorb the changes in a new edition of the DSM. So I'd like to briefly point out some of the changes that resulted in the DSM-5 from the DSM-4. And I'll address mainly some of the more global or philosophical changes. There are also various diagnostic changes in regards to the specific disorders, etc., which will need to be discussed in the context of those specific disorders. You may notice, or you may have noticed in Chapter 6 that there was a lot of discussion between Axis 1 and Axis 2, and one of the kind of points in this chapter was to point out that symptoms that typically are assumed or associated to be with Axis 1 disorders could be a result of Axis 2 disorders. And basically, you can forget all of that, because even though in the real world, people will probably continue to use the terminology for a while, the first major change in the DSM-5 is its abandonment of the multi-axial system. Pardon my typo there. But the multi-axial system is this idea that disorders are understood in terms of 5 axes. And this has been gotten rid of in the new DSM. And so in this chapter, the discussion between Axis 1 and Axis 2 is obsolete. However, the underlying idea there is not obsolete. In the DSM-4 TR, Axis 2 disorders consisted primarily of personality disorders and what was then called mental retardation and other related disorders, or something like that. But basically, there is no Axis 2 category anymore. However, those particular conditions are still contained in the DSM. So the main point still remains, which is that there could be various causes of a specific symptom. And your chapter here gives various charts that detail that. But for instance, again using depression can be obviously a symptom of a depressive disorder such as major depression, but it can also be a symptom or a byproduct of a personality disorder. So someone with depression may not necessarily suffer from major depression is basically the idea here. And so the idea presented of Axis 1 versus Axis 2, the language has changed, but the idea is not. A person with borderline personality disorder, that disorder is no longer classified under an Axis 2 label. However, that disorder could still manifest in terms of depression. Another change in the DSM-5 is what are called dimensional measures. There's going to be, and this follows with the idea presented in this chapter, that there's going to be 8 different dimensions: psychosis, depression, anxiety, and others, that are able to be assessed regardless of a person's diagnosis. Previously, there was no way to identify a particular symptom if it did not occur within a diagnosis. So now there will be a mechanism for indicating that a person, for instance, suffers from depression, even though his or her primary diagnosis is not depression, which falls very much into the line of thinking presented in this chapter. Okay, I'm going on a bit longer than I intended to. This is a very short chapter, and I intend to do a very short overview of some of the changes. And then there are specific diagnostic changes. In other words, individual disorders have small changes in terms of how they're diagnosed, etc. And there's an attempt to be more sensitive to gender, culture, and age in the diagnostic process. And the DSM-5 is more closely aligned with the ICD and the ICF, which is the International Classification of Functioning from the World Health Organization, and I won't touch too much on that here. But again, one of the primary changes in the DSM-5 is the abandonment of the multi-axial system. The DSM-4 TR employed a multi-axial system consisting of 5 axes. Man, my typos are coming out, sorry. Axis 1 consisted of most of the major psychological diagnoses. Axis 2 consisted primarily of mental retardation as it was classified then, and personality disorders. Axis 3 consisted of general medical conditions, and Axis 4 consisted of environmental and social factors, and Axis 5 was the GAF, the Global Assessment of Functioning. And an individual would receive a diagnosis on each of the 5 axes on the previous system. The GAF was a score of 0 to 100, which indicated a person's level of functioning. If a person did not have a specific diagnosis, then there was a code you would put in still for that diagnosis, indicating that the person had, for instance, no medical conditions or no access to disorders, for instance. The non-axial system, which is the current system, combines axis 1, 2, and 3. In other words, each diagnosis is simply listed in order of significance. And so an individual with, let's say, borderline personality disorder and major depression would not receive diagnoses on different axes, but both of those would be listed in terms of significance. And Axis 4 and Axis 5 were eliminated. There is no longer a GAF score, and there is no longer the need to list the psychosocial or environmental difficulties which a person is having unless they're the focus of clinical attention. And I'm going to breeze through this because for our purposes, the main change that affects our understanding is the Axis 1 and Axis 2, and I wanted to make that very clear because the book talks in terms of Axis 1 and Axis 2. In terms of this book, when you read Axis 2, think primarily personality disorders. In this chapter, the primary point that is being made is that personality disorders themselves can manifest in terms of symptoms that might be more typically associated with Axis 1 disorders such as schizophrenia or depression, etc. And there are some specific diagnostic changes, or quite a few actually, but not as major as perhaps some people had thought. But there's, I'm not going to go over these. We'll touch on some of the individual changes in each chapter. There's a recognition of spectrums of closely related disorders with shared symptoms, genetic and environmental risk factors. There's, for instance, autism spectrum disorders. And schizophrenia now is seen as an illness which exists on a spectrum of closely related disorders. There is now a new category of stressor-related disorders. PTSD and others fall in this category, and for instance, PTSD in particular used to be called an anxiety disorder, and now it falls into this new category of stressor-related disorders. And then there are other changes in terms of subtypes, etc., and some disorders that were classified together no longer are, and some of the subtypes have been dropped and changed in different disorders. For instance, the subtypes of schizophrenia, catatonic, paranoid, etc., those are no longer employed in the new DSM-5. And I'm not going to test you on this type of stuff. I'm not going to really do too much with this. What we're really going to focus on in this class is some of the functional difficulties of particular psychological conditions, and more specifically the pharmacological approaches to treatment and the pharmacological effects of particular medications. And there are several new diagnoses, new categories, and some name changes, and some changes in the diagnostic criteria. So in this chapter, the main considerations are that, as I alluded to earlier, there are many causes of specific symptoms, and it is important to try to understand the possible causes of a particular symptom or set of symptoms before jumping to treatment approaches or treatment conclusions. And there's a brief discussion of substance abuse. Substance abuse itself can lead to symptoms which themselves appear psychological in origin. And so if a person is depressed because of substance abuse problems, then that might affect the considerations of a pharmacological approach, for instance. And there's a quite detailed discussion of physical illnesses, and I'm not assuming that you're going to absorb all this or memorize all this, but it's important to understand that physical illnesses themselves result in symptoms, and so often more than a person might imagine. Someone might come to your office, for instance, if you're a counselor, with symptoms of depression, anxiety, even psychosis, and those symptoms are being caused by a medical condition. And so what really needs to be treated is the medical condition. And in that case, a pharmacological agent is not what is necessary, but some sort of medical treatment. I remember one particular hospital setting I worked in, psychiatric inpatient hospital, and one of the psychiatrists would routinely have people's assessed for ear infections if they had a particular set of psychotic symptoms, because in her mind and her experience, these symptoms were sometimes associated with ear infections. And in my couple of years history working with her, there were multiple occasions with individuals who came to the psychiatric setting because of psychotic symptoms. Those symptoms themselves were traced back to a particular medical condition. So it's important to for instance, look at the specific physical symptoms checklist on page 73 of your text and just get a feel for the fact that a possible disorder, health condition, can result in physical symptoms, but in addition to the physical symptoms, it can also manifest in psychiatric symptoms. So basically, in clinical assessment, it is important to consider the multiple factors that may contribute to a person's symptoms. It is important to rule out certain potential causes in the diagnostic process and to take a very complex approach to individuals, understanding that there are many causes of symptoms, and to not assume that a person's symptoms are a result of a specific cause until you've done a little bit of research and information gathering in the context of a given individual.